It is, make it so at least I can't hear you talking over me. It is my pleasure to get to introduce Haley Simmons, and please again forgive me for not being able to read. Haley Simmons is an athletic trainer, a clinical and surgical athletic trainer at the Stedman Clinic in Vail, Colorado. She began her athletic career at the University of Iowa, working as a traditional setting athletic trainer for the softball team before coming to the Stedman Clinic to complete her residency program. After the completion of the residency, she joined the full-time clinic, working with knee and shoulder surgeons, both in the clinic and operating room. So please join me in welcoming Haley with her presentation.
Thanks for the introduction. Like you said, my name's Haley Simmons, and I work at the Stedman Clinic out in Vail, Colorado. So today we're going to be talking about updates on recognition and surgical treatment for cartilage injuries in the knee. Before we get started here today, I have to give a ton of credit to my colleague Cynthia Wright, who worked on this presentation with me. She couldn't be here today, unfortunately, but she is actually presenting this same talk at NWATA over in Washington State today. So we're bummed we couldn't both be here together or there together to present it, but presenting in two places at once is a pretty good trade-off for that. So as we get started, neither of us have any conflicts of interest to disclose today. We do have a couple disclaimers, the main one being that while today's presentation is going to focus partly on surgical management, we are obviously not surgeons, we are athletic trainers. We did consult with my boss, who is a complex knee surgeon at the Stedman Clinic, on the content in the presentation today. But the point being is that this is a presentation for athletic trainers by athletic trainers, and we are advocating that athletic trainers do have a role in the recognition, conservative treatment, counseling, referral for surgical management, and postoperative rehab for patients that do have chondral injuries. So 4 main objectives for us today. First, that we want patients or participants to be able to identify typical clinical presentation of knee cartilage injuries. Second, to be able to recognize basic signs of cartilage injury on imaging, specifically X-ray and MRI is what we're going to go over today. Third, that participants will be able to define surgical options for knee cartilage injury. And finally, that you will be able to compare and contrast the indications and outcomes for surgical options for knee cartilage injuries. So what got us starting to want to work on this presentation for you guys today is Cynthia and I were talking in clinic one day about how minimal we felt like our education was on cartilage injuries in our undergrad programs. And like I mentioned earlier, Cynthia is a professor at Whitworth University, and she teaches the evaluation course there. And she, looking back, was like, admittedly, I think I have one slide on cartilage injury in my knee talk. And looking back at my undergrad education, I think mine was pretty similar. And so we can't ignore the fact that ligamentous and meniscal injuries are definitely more common in our young athletic populations, whether it's at the high school, college, or professional setting. But it doesn't mean that cartilage injuries aren't there, and they're actually probably seeing us more often than we're seeing them. So how common are these in athletes? Flanagan et al. Tried to answer this question for us about a decade ago through a systematic review. They found that 36% of athletes had full thickness chondral defects, and specifically focal chondral defects, diagnosed either on MRI, through arthroscopy, or a combination of both. Athlete was defined as anyone who trains and competes in games or exhibitions. Now, interestingly enough, 14% of these athletes with full thickness chondral defects were asymptomatic. And you might be wondering, why did these athletes even get an MRI or go through a scope in the first place if they were asymptomatic? But a handful of the studies that were included in the systematic review were reporting on either screening MRIs done in like the NBA or NFL Combine, or as like a preseason evaluation screening. So now looking at prevalence based on location in the knee, femoral condyle or patellofemoral lesions were the most common, followed by femoral condyle and then tibial plateau. And amongst the femoral condyle lesions, medial were more common than lateral, and in the patellofemoral joint, patellar defects were more common than trochlear defects. Another study here looked at 1,000 consecutive knee arthroscopies and found that focal chondral or osteochondral defects were found in 19% of knees, regardless of the surgical indication. So no matter why we went in for the surgery in the first place, 19% had a focal chondral defect in there. And interestingly enough, in these arthroscopies, 61% found cartilage defects of any kind. So meaning that they weren't necessarily a focal lesion, but they could have been a more diffuse wear pattern throughout the knee. So 61% of these. The bottom line here is that more of your patients than you probably think have chondral injuries of some kind, whether they're asymptomatic or not. Cartilage pathology can be the source of unexplained or unresolved cases of knee pain and swelling if you don't know what signs and symptoms to look for in your athletes. So the longer that I've worked under my boss, who kind of specifically specializes in cartilage pathology, I've thought back to the cases of a lot of my previous athletes and patients and wondered how many cartilage injuries I either missed or misdiagnosed. So to some extent, this presentation is what I wish I would have known earlier on in my athletic training career. So we'll start with clinical presentation and how they may present on history. So first, these patients often come in with a chief complaint of knee pain with weight bearing, and that pain is often localized to the compartment where their cartilage defect lives, which makes sense. These patients often complain that their pain may only be elicited in a specific range of motion. So for example, their pain in a squat may only be from, say, 0 to 45 degrees is pain-free, but 45 to 90 might be painful, as that is when that defect is engaged throughout that range of motion. Additional symptoms can often include a joint effusion with activity. This is a pretty cardinal sign of cartilage pathology, as well as mechanical symptoms such as clicking, catching, or locking. Intermittent joint line pain is another common symptom if their cartilage lesion is near their femoral condyle or tibial plateau along that joint line. And lastly, patellofemoral defects can present very similar to our kind of generalized patellofemoral pain syndrome or generalized anterior knee pain patients. One way to help you rule these out, I should say, is the presence of effusion in the joint, and this is going to be common with our patellofemoral cartilage defects, but not so much with our generalized anterior knee pain patients. So on examination, I know us as athletic trainers really love our special tests, but there really aren't any great special tests for cartilage pathology. If you look in the literature, Wilson's test is probably going to be what you see most often. And that involves having a patient sit at the edge of the table with their knee bent to 90 degrees. You then internally rotate their tibia, extend that knee. Pain is most commonly felt at about 30 degrees or so. And Wilson's test is positive if pain is relieved with tibial external rotation. So I can't say I've ever seen my boss or any other physician I've worked under use this clinically, but it's something good to know because it's what you're going to see in the literature most often. Possible findings on functional assessment can reveal abnormal squat or gait analysis, abnormal patellar tracking, or muscle imbalances, and these are often due to pain compensations that they're making due to their defect. Again, if their defect is near the joint line, they can present with joint line tenderness. They can have decreased range of motion secondary to pain. Effusion, again, this is a very cardinal sign of cartilage pathology. And again, it's important to remember that in our young, healthy athletes, which a lot of us are dealing with, ligamentous insufficiency or meniscal involvement can be seen as well and should be assessed for and ruled in or ruled out, because a lot of cartilage pathology in these young athletes can occur secondary to a traumatic event. So to hopefully make all of this make a little bit more sense today, we're going to follow two case studies throughout the course of the presentation. Our first one here is JL. He's a 40-year-old male who presented to our clinic with right anterior lateral knee pain that started without a traumatic event while skiing in March. By July, his progressive knee pain was then preventing any form of impact or resistance activity for him. He described his pain as constant, dull, aching, and occasionally sharp and stabbing. It's pretty common with our athletes where they give us 5 different things to describe their pain. Clinical presentation, he presented with a small decrease in range of motion on his affected right side. He had a mild effusion in the joint and was tender over the anterior lateral condyle without any joint line tenderness. He was ligamentously intact, negative McMurray's, and had normal patellar mobility. Our next case here is CM. She's a 26-year-old female with left knee pain. She had a history of multiple prior patella dislocations, and about a year and a half before presenting to our clinic, she underwent an MPFL reconstruction, which helped her with her recurrent dislocations. However, she continued to have significant patellofemoral pain and crepitus, specifically with activity. On clinical presentation, she had full symmetric range of motion bilaterally. She was tendered palpation over inferior and lateral patellar facets and had no apprehension or J sign, so that MPFL reconstruction was working really well for her. And then she had palpable patellar crepitus throughout her range of motion. So both of these cases present with signs and symptoms that raise suspicion for cartilage pathology. However, while we can suspect cartilage pathology based off their history and our exam findings, definitive diagnosis does require further imaging. So whatever our practice setting, we need to be working with an interdisciplinary team to make sure that our athletes have access to that higher level care and higher level imaging when necessary. And so it's our job as athletic trainers to first be able to recognize these things and then recognize when they need that referral for higher level care and higher level imaging. So before we jump back into the imaging for these case studies, we're going to go over generalized imaging and what to look for in the case of suspected cartilage pathology. So X-ray is the first step for imaging that we usually get, particularly to rule out other pathologies, but also to look for possible bony malalignment and decrease of joint space. An individual with cartilage pathology may present with fairly normal radiographic findings. Typically, we'd like to see at least 5 views, being an AP, a lateral, a tunnel, a merchant, and a long-standing. We'll go through all of those here in just a second. So we'll start with our AP view, which is an anterior to posterior view on the left side of the screen here. These are typically taken with the patient standing in full knee extension. What we're looking at specifically here on this X-ray, outside of the bigger, more acute things such as fracture, are the joint spaces. And when I say joint space, I mean the space between the femoral condyle and the tibial plateau, as these directly reflect the amount of cartilage in the joint. So the more narrowed the space, the greater the cartilage loss. The view on the right here is very similar and maybe a little less common. It's a notch or a tunnel view. It can also be referred to as a weight-bearing flexion view, as that's exactly what it is. So it's very similar to our AP view here, but instead the patient is in about 45 degrees of knee flexion. And this is helpful to assess the joint in a more functional range of motion, because life and sport does not happen in full knee extension. It happens typically in low levels of knee flexion. So this helps us to assess the knee in a more functional range of motion. Our next X-ray here is a merchant or a sunrise view. So obviously this is a great view of our patellofemoral joint. We can see that patella and how it sits in that trochlear groove. As we look at that top photo there, that's a nice, healthy patellofemoral joint. Again, we're looking at joint space, we're looking at smoothness of articular surfaces. In this, we can also appreciate if the patient has any excessive patella tilt or lateral tracking. The bottom photo here is a good example of both of those. So this patient has well-maintained joint spaces in the patellofemoral joint, but you can see they sit laterally, tracking-wise, and have some excessive lateral tilt. Both of those things can overload that lateral side of the patella and overload that cartilage underneath and are predisposing to cartilage defects there. Next is our lateral view. This is not the best view to appreciate joint space on, but this is the best view to look at patients' patella height. So you can take measurements on this lateral X-ray to quantify how much either patella baja or patella alta that a patient has. We're not going to dive too deep into how to do all that today, but you will see those measurements done on some of the case studies X-rays as we get into those. So finally, this long standing here, or a hip to ankle, and this helps us assess coronal alignment and the weight-bearing axis of the patient. So a line is drawn from the center of the head of the femur down through the center of the ankle, and where that line falls through the knee joint shows us where that patient transmits load through their knee. So neutral alignment would be that line falling directly through the tibial spines in the center of the knee. So this patient on the left side of the screen here, it's important to note that these X-rays are taken as if the patient is looking at us. So when I'm talking about the left knee, it's actually the knee on the right side of the screen. So X-rays on the left side of the screen here, the affected knee is the left knee. If you look at the zoomed in photo of those knees just next to it, you can appreciate those 2 yellow lines. Their unaffected, asymptomatic right knee, that line falls straight through the middle of their knee in neutral alignment. And then if you look at the left affected knee here, that line falls more through their medial compartment, meaning that they are in varus and maybe overloading that medial compartment of their knee. Exactly opposite to that, our X-rays on the right side of the screen. Again, we follow those plumb lines down through their knees there. Their unaffected right knee falls neutrally right through the middle of the knee. And then the plumb line on the left knee there falls through the lateral portion of the knee, meaning that they are in valgus and maybe overloading that lateral side of their knee. What's really important to note here is that both of these patients give us a good example of being asymmetrically in either varus or valgus. So obviously, everyone is built a little bit different, and some people are more varus, some people are more valgus. But these patients on their affected knee have either some kind of asymmetry. So they're either asymmetrically in varus or asymmetrically in valgus. So this makes us perk our ears up a little bit and is a little bit of a red flag for us. So as we dive into MRI and looking at cartilage pathology on MRI, I wanted to start with normal cartilage here. So these are our three main cuts of MRI: axial, sagittal, and coronal. These are T2 weighted images, meaning that our bone shows up nice and dark gray. At the end of the bone on the articular surface, that thin black line is our subchondral plate. And then the thin gray line on the very surface of that joint is our articular cartilage. So we like to see that bone nice and dark gray, nice and quiet. We like to see an intact thin black line for that subchondral plate and nice smooth gray cartilage on the end of that. So keep these pictures in mind as we go to some not so normal cartilage here. So we'll start at the patellofemoral joint. The sagittal view on the left, we're looking at the undersurface of the patella here. At the very top, you can appreciate maybe a little bit of healthy cartilage up there, but as we try and follow that gray line down where those red arrows are pointing, we kind of completely lose that gray line, meaning that they have cartilage loss in that area. A good example to reference it to is if you look at the opposing side, the trochlea, they have that nice thick gray line on the end of the bone there. If you look over at our axial on the right side of the screen here, shows that patellofemoral joint a little bit better. Again, we're looking for that nice smooth gray line on the end of the bone, and those red arrows are pointing to those big old chunks that we have missing in that cartilage surface there, both on the trochlea and on the patella up top there. So with cartilage injury on MRI, we can also see what we call bony edema. So like I talked about, we want to see that nice dark gray bone, meaning that bone is quiet, but cartilage serves as a buffer for our bone, and when that is either damaged or missing, our bone starts to see an increase in load that it is not used to and doesn't like. So as that happens, we can start to see a reactive change in the bone, and that's all this bright white fluid that these asterisks are indicating on the left side of the screen. We want that to be nice and dark gray, but we're seeing all this bright white in there indicating fluid in the bone, which is a reaction to the increase in stress that it's seen from that cartilage damage. We can also see bony edema in a more traumatic setting. So this axial on the right here you can appreciate the bony edema on the medial side of the patella and the lateral trochlea. And so this is an indication that this patient acutely underwent a lateral patella dislocation. And so you can kind of picture it, as that patella slipped out on the lateral side, that medial patella and lateral trochlea banged into each other. And then we get these kind of opposing areas of bony edema, indicative of that patella popping out on us recently. So some more abnormal cartilage here, now looking at the femoral condyles. Again, we want to be able to see that nice smooth gray line of cartilage at the end. On our coronal on the left, those white arrows are pointing to that area of cartilage loss, and we're starting to see some reactive change in the bone there. On the sagittal, you can really appreciate the gray cartilage coming around the posterior side of that femoral condyle, and then through that weight-bearing surface, it all turns into white, and that white is joint fluid filling in that empty space where that cartilage should be. And then again, on the far right side of the screen here, our coronal, the white arrow pointing to that area of cartilage loss, and we're starting to see some very early change in the bone there with a little bit of bony edema there. So we'll hop back into our case studies now that we kind of know what to look for on imaging. So this is JL, again, our 40-year-old male with right anterior lateral knee pain who presents with very normal radiographs. And so we look at his AP, he has well-maintained joint spaces there bilaterally. We look at his lateral. These are the measurements I was talking about. It's called a CD ratio measurement that we did on this x-ray here. And he does sit at a little bit higher of the normal limits for patella height, but within normal boundaries. And then his long standing here. This is a really good example of someone who is just built a little bit in varus, but he is symmetrically and bilaterally in a little bit of varus here. So this doesn't raise any huge red flags for us. It's actually maybe a little bit protective for him because he has lateral cartilage wear, and he sits a little bit medially. So this really shows the importance of if our clinical exam and our history make us suspicious for cartilage pathology, and then we get x-rays and those are normal, there is value in getting an MRI. So he has a very impressive MRI here. We'll start with our sagittal on the left side of the screen. If you follow that gray cartilage line around, you actually don't see any huge defects in his cartilage on this MRI, But we can see change in his subchondral plate just underlying that, where that red arrow is pointing, and obviously all this bony edema showing that that bone is seeing higher loads than it wants to. On the axial, you can appreciate his cartilage damage just a little bit better there. We're following that gray line on the trochlea, and you can see that little crack in it where white fluid has filled in. And again, change in his subchondral plate and all that reactive bony edema there, both in the axial and the coronal there. So I want you to keep this mental picture of what his MRI looked like here, where we're not seeing this huge defect in his cartilage, because as we jump into his surgical photos a little bit later, this is going to make a lot more sense. So next, we have CM, our 26-year-old with patellofemoral pain. Again, her x-rays present pretty normally. Her long-standing, she is bilaterally in neutral alignment. We're looking at her left affected knee here in her sunrise view. She has a small decrease in joint space there, a little bit of irregularity in her articular surface, which you can really appreciate when compared to her unaffected right knee in that image. And then again, her lateral here, her CD ratio is not shown on this, but you can appreciate a small little infrapatellar osteophyte forming there. And it's hard to see, but you can see a little tiny black dot at the top of her patella, and that's actually a normal finding. That's her tunnel from her previous MPFL reconstruction that we're seeing there. So moving on to her MRI, on her axial here, again, we want to see that smooth gray line of cartilage, and you really can't appreciate much at all on her here. And then her patella there, while it's not this one single spot of bony edema, we want to see that nice and dark gray. It's kind of lit up and diffusely edematous there. The green arrow is pointing to her MPFL reconstruction. It's not the best cut of it, but you can see that intact MPFL reconstruction. The little spot of white that you're seeing on her femur in this cut is actually not bony edema. That is artifact from her hardware from her MPFL reconstruction there. Again, on her sagittal here, those two black dots are those tunnels I was talking about on the x-ray, again, from her previous reconstruction, normal findings. But we want to see that smooth gray cartilage line, and you can appreciate a little bit at the top of her patella, but as we work that way down, we lose that gray line, indicating that she has severe cartilage loss on the back of her patella there. So now that we have gone through imaging and what to look for, we will start talking about treatment. So treatment exists on a spectrum, and on the left side here, we have conservative options such as therapy, activity modification, bracing, NSAIDs, weight loss, etc. And all of these things are going to be the first line of defense for treating cartilage lesions. And these things are oftentimes going to fall under the management of us as athletic trainers. So if they fail to produce adequate results, the patient can be referred for various types of injections, ranging from corticosteroid injections to PRP or other biologics, potentially hyaluronic acid injections. Again, if they fail these, then we will start the discussion on potential surgical options. And it's these surgical options, starting from arthroscopic chondroplasty, ranging to bony and cartilage preservation procedures that we're going to focus on for the remainder of this talk today. We are not going to be talking about unicompartmental or total knee arthroplasty, but it's important to note that if the patient does continue to fail our interventions, that is what they're left with. So in the literature, there are many algorithms that try to create a pathway for deciding how we seek appropriate treatment for our patients. And it's tough because there's no one cookie cutter, one size fits all pathway for this, but these algorithms try to give us a little bit of a pathway to follow. So this algorithm here focuses specifically on athletic cartilage lesions in football athletes. They base their decision-making around comorbidities in the knee, size of the lesion, and depth of the lesion. They raise a very important point here regarding comorbidities. So especially in our young, healthy athletes, like we talked about, cartilage lesions can often occur secondary to a traumatic event in the knee. And so if we're not assessing the knee and ruling in or ruling out other concomitant injuries in the knee, and we go to treat the cartilage, we're gonna end up right back where we started, because an ACL tear or a meniscus root tear are gonna place uneven loading and higher stress on that cartilage. So if we go to repair that cartilage and don't treat those other things, we're gonna be right back where we started in square one. So I think it's very important that they have this at the top of their algorithm here. And so assuming that comorbidities are addressed, they show a way to kind of work down this here. So For example, they propose that for a large lesion, which only affects the cartilage and not the underlying bone, a matrix-induced autologous chondrocyte implantation, or a MACI procedure, would be their primary choice, and then an osteochondral allograft would be their secondary choice if that does fail. So when it comes to surgical options, the key is selecting the right procedure for the right patient. Like I said, this is not a cookie-cutter, one-size-fits-all surgical discussion, so we need to be choosing the right procedure for the right patient to achieve the best outcomes. This is a discussion that takes place amongst the healthcare team, but is led by the surgeon with the patient. So I present these algorithms today, and we're going to talk about all these surgical procedures, not as materials that athletic trainers should memorize so that we can decide what type of surgery that the patient needs, but as resources to help athletic trainers understand why perhaps a surgeon may choose an OATS procedure for one patient and a chondroplasty for another patient when they clinically present very similarly. So within the literature, there is no consensus regarding the perfect algorithm. There is significant surgeon discretion, although there might be common themes amongst those surgeons, especially regarding the size of the lesion and the desired activity level of the patient post-operatively. So one role of an athletic trainer might be to serve as a patient advocate and advisor in this as we start to go down this surgical pathway. My goal with this presentation is that you're not only able to better recognize cartilage injury, but also feel more equipped to discuss various types of surgical procedures with your patients. And we're not here to override or subvert the surgeon's decision, but rather to partner with them in providing appropriate patient care as we go down a surgical pathway. So as we talk about these surgical procedures, we're going to cover 3 basic elements in all of them: the basics of the surgical technique, considerations and outcomes for them, and then any updates on the technique. It's very important today that we're going to stay at a 10,000-foot view of everything. We are not going to dive into the nitty-gritty of any of these surgical procedures. We're going to focus on the basics that are going to help us as athletic trainers to better understand how we can provide better education for our patients. So we're going to start with the most basic here in arthroscopic chondroplasty. So chondroplasty refers to the smoothing of degenerative cartilage and trimming of unstable cartilage flaps to stabilize and treat cartilage lesions. This is a great first line of defense as it has the shortest recovery time of all of our procedures and has patients' weight bearing is tolerated right after surgery and usually back to their desired activities within 4 to 6 weeks. Chondroplasty can serve a big role during staging scopes, which are often used as a first step in treating cartilage lesions. While MRI can give surgeons a good idea of what a cartilage lesion looks like and the character of the lesion, a staging scope actually allows for the patient or the surgeon to go in to take a look at the lesion firsthand, take measurements, and very importantly, assess the rest of the knee for any damage as we determine what the best definitive procedure is going to be for that patient down the road. So chondroplasty is often done at the time of these staging scopes in order to obtain accurate measurements of the lesion, but also hopefully to provide some relief for the patient as well. So as we go in and trim up any of the loose flaps of the cartilage here, we're hoping to resolve some of their symptoms moving forward as well. So I think these 3 surgical photos on the bottom here really help to put this in perspective. So the far left is what that lesion looked like when we first went into the joint. The middle photo shows us going in with our arthroscopic shaver to debride those loose flaps on the end and any unstable cartilage around the periphery. And then the picture on the right shows what that lesion looked like once we were done debriding away everything that was unstable. And so you can really appreciate the difference between the start and the finish of that. And that is hopefully helping that patient decrease their symptoms, but it also gives us a better idea of what the true size of the lesion is for when, if or when, we have to go back in and definitively treat this cartilage lesion. So another thing we can do during staging scopes is harvest chondrocytes. And these are harvested from a non-weight-bearing part of the knee in forms of 2 to 3 little tic-tac size pieces of cartilage. And we usually take them from the notch of the knee. These biopsies are then sent off to a lab and they can expand these chondrocytes back into a form where we can implant them back in the knee to treat the patient's cartilage lesion later on. And we'll go more into depth on that surgery in just a bit here. So an important consideration for chondroplasty is that it does not fix the lesion. We did not fix anything. Potentially we made their lesion look a little bit bigger by going in there and debriding it, but we are hoping that we can decrease symptoms at the time of this. And anecdotally, my supervising physician reports that 60% of the time, the second stage in the definitive procedure that the patient needs is actually canceled because the adequate outcomes are achieved with just the chondroplasty alone. So whether we end up delaying that procedure or canceling it completely, that is a huge benefit from a quick staging scope that carries very low risk and has a very quick recovery for the patient. So next procedure we're going to talk about here is marrow stimulation, which is also very well recognized as microfracture. Microfracture involves first debriding the cartilage lesion to create clear walls around the lesion, as you can see in picture 1 up here. Then a microfracture awl, which is this kind of sharp metal pick, is inserted, and a mallet is used to create small little holes all throughout the cartilage defect, which you can see in pictures 2 and 3 there. These microfractures then create a bed of bleeding bone, as you can see in picture 4, which stimulates a healing process that can allow for that cartilage defect to fill in with scar tissue. That scar tissue can include high-quality hyaline-like cartilage, but it typically is a higher percentage of fibrocartilage, which is neither as functional nor as durable as our native hyaline cartilage, which can lead to worse long-term outcomes for the patients when compared to other preservation techniques that we'll talk about moving forward. So indications for microfracture include full-thickness chondral lesions that have a post-debridement lesion size of less than 4 centimeters squared, so this does not work well for our big cartilage lesions. This procedure has best results in patients that are less than 40, who are not obese, and have a relatively recent onset of symptoms. Marrow stimulation techniques tend to have very good short-term results. For example, in one study, 2-year revision rates ranged from just 2.5 to 6%. However, the longer the follow-up period, typically the higher percentage of patients who return for revision surgery of some kind, up to 9 to 31% at just 5 years out. So while marrow stimulation techniques have achieved relative notoriety in the past, our current understanding of their limitations, especially their tendency to fail at increasing rates after 2 to 5 years, have significantly narrowed their indications. While still an acceptable technique in some scenarios, this is no longer a preferred treatment for our patients. Another reason it's less preferred is because the damage this technique does to the subchondral plate, and that can limit the future options for surgical intervention for our patients moving forward. There are clinical trials underway to ascertain whether certain medications can influence the formation of the scar tissue that we see fill in, and they're hoping that this can help the body form less fibrocartilage and more hyaline cartilage as that scar tissue fills in the defects. And while promising, to date, robust clinical data on this is still pretty lacking. So autologous cartilage or chondrocyte implantation, known as ACI, quite the mouthful, or matrix-induced ACI, known as MACI, the kind of more recent branded version of the surgery, is another option for our patients with focal chondral defects. This procedure is performed in 2 stages, approximately 3 to 8 weeks apart. Stage 1 involves that arthroscopic debridement of the cartilage lesion, taking biopsies of the patient's own healthy cartilage, like we talked about earlier. So these are harvested again the chondrocytes are harvested in 2 to 3 little tic-tac sized pieces of cartilage from the notch of the knee. And then these are sent off to a lab, and that lab can then culture these to grow more healthy chondrocytes specific to the patient. The lab then sends back those expanded chondrocytes for implantation back into the patient, into their cartilage defect. This second stage is an open surgery, so it's a much longer recovery and a little bit bigger deal to go back in for the second one. And this involves the cultured chondrocytes. In our original version of ACI, they come back in a vial where we inject them back into the chondral defect, and then they are placed and covered with a periosteal patch that's then sutured into place to hold those chondrocytes in the cartilage defect there. We'll go through what the kind of more updated version of this surgery is in just a bit. So early research showed that this technique resulted in hyaline-like repair in rabbit models, with 74% of the defect being filled in with normal collagen, which is much more appreciable compared to our microfracture technique that we just previously talked about. However, these procedures carry a relatively high revision rate and complication rate. Some of the most common complications are periosteal hypertrophy, where the cartilage grows beyond the boundaries of the original cartilage lesion, and arthrofibrosis, which is stiffness of the knee. So this technique works best in patients who have not had prior marrow stimulation techniques. So patients that have undergone ACI or microfracture previously are not great candidates for ACI. Additionally, research has shown better outcomes for certain types of defects. For example, trochlear defects treated with ACI have better outcomes than patellar defects treated with ACI. So finally, the major update to this surgical procedure is that our original technique of ACI, where those chondrocytes are injected back into the lesion, has been largely superseded and replaced by MACI. The difference here is that MACI, the chondrocytes are embedded into, as they're grown, are embedded into a porcine membrane. We then get this patch back that kind of looks like that picture on the top right side of the screen there. And then we can cut a patch out of that directly fits into the cartilage lesion, which you can see a MACI implant in a patient's knee on the bottom side of the screen there. So this is believed to have a little bit better outcomes, but it definitely is a much easier process on the surgical side as well. So another surgical technique that has pretty high name recognition is the OATS technique, and this stands for Osteochondral Allograft Transfer System. This technique uses autografts harvested from the patient's own knee in either in the intercondylar notch or the lateral trochlea, so an area of the knee that sees very low loads. The affected cartilage in the joint is then reamed out in sizes that perfectly match the harvested autografts, and the autografts are then placed into those reamed spots to create a new healthy cartilage surface. Healing then occurs bone to bone between the graft and the patient's own underlying bone. This is an open procedure and can be used to treat cartilage lesions ranging from 1 centimeter squared to 4 to 8 centimeters squared. So when considering an OATS procedure, donor site morbidity, or the cost that we pay to harvest those grafts from the patient's own knee, is a very important consideration. So even though the autografts are harvested from a part of the knee that sees very low loads, such as the lateral, the far periphery of the lateral trochlea, we are essentially creating new defects that can become symptomatic for the patient. So we're fixing their initial problem, but we are essentially creating new ones for them as well, and these can become symptomatic. So on the flip side, the benefit to using an autograft is that the OATS has a relatively low graft failure rate, ranging from just 0 to 8%, and a very low complication rate ranging from 3 to 9% at the grafted site. So we're not talking about the site where we harvested these grafts from, we're just talking about the site where we put them in. So due to the concern for the donor site symptoms that we see with this procedure often, this procedure has largely fallen out of favor and has been superseded with the next surgical procedure that we're going to talk about here. And so the next one here is an osteochondral allograft, and at its most simplest level of understanding, this is essentially an OATS procedure, but instead of using autografts from the patient's own knee, we use allografts. And so for this procedure, a fresh cadaver allograft is obtained, and during an open surgical procedure, the chondral lesion is again then reamed out to an area that fully encompasses all the damaged cartilage, and then that matching graft from the cadaver is then harvested to match the same size we reamed out and then placed into that reamed hole. So you can appreciate the kind of steps of this procedure on the bottom here. We start with our initial cartilage lesion on the left. We then ream that out completely to get out all the diseased cartilage. We harvest a matching graft from our cadaver, and then that cadaver plug is placed into that reamed hole to create a nice smooth cartilage surface there. So unlike our OATS procedures, which are limited to relatively small lesions because we're taking grafts from another part of the knee, the osteochondral allograft can treat large lesions because we don't have to worry about that graft causing donor site morbidity at another part in the knee. Also, the cadaver graft that we receive is very carefully matched to the patient for size prior to surgery. So that allows us to match the contour of the patient's either femoral condyle, trochlea, or patella, whatever we're fixing in that scenario, very closely. An osteochondral allograft can also be considered a salvage procedure because, like you can see in this, we ream out everything that was previously done. So if the patient has failed prior intervention, this can be a salvage procedure because, like I said, we're going to take all of that out of there as we ream that out to put the new graft in. So a very large consideration for this is that osteochondral allografts are often limited and regulated by donor availability. So these patients go on a donor list. There's typically a 28-day window from cadaver donation to surgical use, which helps us maintain the chondrocytes. So these are fresh grafts, they are never frozen, so we're on a pretty tight timeline to use them. The true surgical window that we get is even smaller because the donor grafts have to undergo extensive testing before they're released to us for surgical use. So the surgical window really ends up being closer to 10 days or so. So patients on their end need to be very flexible with the timing of their surgery because we'll get a notification that we have a graft that matches for them, and we're gonna call the patient and be like, hey, you're having surgery in 3 days, and so they need to be ready for that. Looking at outcomes, there's an inverse relationship between the size of the defect and postoperative outcomes, indicating that smaller lesions have better outcomes, which makes sense. One study reported that a survival rate for osteochondral allografts ranged from 78 to 87% at 5 years, which is very respectable compared to some of our other techniques we've talked about. In the study, they defined failure to survive as a patient who had to go on to revision surgery or went on to a total knee arthroplasty. The survival rate does drop quite a bit to just over 50% at 15 years. So you might be wondering, why would we sign up for a procedure that has a 50% failure rate at 15 years? But if you consider a patient that has debilitating knee pain, they're too young for a total knee, if we're able to delay their need and their progression onto a total knee for 10 to 15 years and decrease their pain, increase their function for those 10 to 15 years, that's a pretty big win. And so we, both as the healthcare team and the patient, might consider that procedure still a success. So this final procedure we're going to talk about does not actually directly address the cartilage, but rather it adjusts bony malalignment in the knee. So by correcting malalignment, you can unload a singular compartment of the knee to either unload damaged cartilage that we're going to choose to leave alone, or to protect a cartilage graft that we placed in the knee. So there are 3 main types of osteotomies that we're going to talk about, and they each serve to unload a different part of the knee. So the first one we have is a distal femoral osteotomy, and that's the picture on the left side of the screen here. A DFO involves making a surgical cut in the distal femur, and then we kind of wedge that cut open, which you can see, and place a plate on it to hold it in place. We do backfill the wedge that we make for extra stability there and to help with healing. So DFOs are most commonly done to unload the lateral compartment of the knee. And the next procedure is very similar to this, a high tibial osteotomy, which is essentially the same thing as a DFO, but instead it's happening on the proximal medial portion of the tibia. Again, we make a surgical cut, we open that, and then we put a plate on that to hold it in place. So both HTOs and DFOs aim to shift the weight-bearing axis to a more anatomically neutral position to intentionally unload diseased cartilage or protect a cartilage graft that we put in there. So now we're thinking back to those long-standing x-rays that we saw, where that plumb line was falling through either the medial or lateral compartment of the knee. These surgeries are helping us move that plumb line back to the central part of the knee to unload the diseased compartment of the knee. So third, we have a tibial tubercle osteotomy, and TTOs anteriorize and medialize the tibial tubercle. And these are done in order to correct patellar alignment and or to unload patellar or trochlear cartilage defects, again, that we're gonna leave alone, or cartilage grafts that we have put in these locations. So as athletic trainers, we're very familiar with the concept of finding and fixing a biomechanical root cause of pain. So for example, if the root cause of knee pain is weakness in the hip external abductors, then we can treat the knee all day, but if we don't address their hip weakness, then the patient is still gonna be suffering from knee pain. So osteotomies function very similarly here. They're looking to fix a biomechanical root cause of knee pain, specifically bony malalignment that leads to uneven cartilage loading. So osteotomies are often performed with other cartilage procedures, but can also be performed on their own. Research has shown improved outcomes such as better patient-reported outcome measures in patients that undergo osteotomy and a cartilage procedure such as ACI as compared to just ACI alone. Additionally, osteotomy has been shown to delay or prevent the need for total knee arthroplasty by unloading that diseased cartilage and in turn buying more time with the patient with their native knee. However, we have to keep in mind that these osteotomies are very big surgeries, and patients are often non-weight bearing for 6 weeks to allow for that fracture site to heal. On the right side of the screen, you can see pre- and post-surgical images of a patient who underwent a DFO. You can see both visually and radiographically the drastic change in the patient's weight-bearing axis as they are brought from valgus into a more anatomically neutral position here. So an important consideration for osteotomy is how the rest of the knee looks. So think of a patient who has a lateral condyle defect. If we want to unload that, but the patient also has medial compartment wear, we're just unloading bad cartilage onto more bad cartilage. So we need to make sure the opposing side of the patient's knee has healthy cartilage that can take the increase in force that they're going to see with the osteotomy. And finally, one update to osteotomies is there are some new emerging technology which allows for 3D printed guides to help us with our osteotomies. And these are patient-specific guides, so they're 3D printed to match the exact anatomy of the patient, which can help us with more precise cuts and can potentially lead to better outcomes, but too soon to tell that. So now that we're familiar with all these different surgical techniques, we're gonna hop back into our surgeries for our case studies here. So back to JL, who had our right anterior lateral knee pain. If we start at the top, we're looking at his surgical photos here. So remember what his MRI looked like. It was like this little tiny crack in his cartilage that we could see, and that exactly matches what we see when we get in there. He has this big fissure down his cartilage, but as we debride back all of that unstable cartilage, you can then see the true size of his lesion, which tells us and shows us why he had all of that reactive bony edema. So moving over to the next picture to the right, we start to remount that damaged area of cartilage. We then, moving down to the bottom left, start to plug that. Because of the size of his lesion, we actually had to use 2 plugs for him. So that next photo over to the right shows those 2 plugs in place. The little holes you're seeing in the middle of those are actually small screws that were placed to help with fixation because of the size of his lesion. Those are sunken way down, so they're far below the cartilage surface, so the patient will never feel those. He also underwent a TTO, and again, remember TTOs anteriorize and medialize the tibial tubercle, so by doing the TTO, we are unloading his lateral trochlea where we just put in these cartilage grafts. So next, CM, our patellofemoral patient, so we did a staging scope on her, and in these scope photos, you can really see the difference in her healthy white cartilage on the left side of her patella, and then all of her damaged cartilage that kind of looks almost like shredded and a little bit like crab meat on the right side of her patella. At this time of the staging scope, we did a small chondroplasty on her. We also harvested chondrocytes, which were then sent off to use for her second stage here, where she underwent, again, a TTO and a MACI to her patella. So as we follow her surgical photos across the top here, we can see her damaged cartilage in the first one on the left. We then take out all of that damaged cartilage, create clear walls, and then we directly harvest the same size plug out of the patch that we got back from her MACI, and then that is placed into her cartilage defect, which you can see in these last 2 pictures on the top right. She does have a couple sutures in there that you might be able to see, and that was just placed in there because this was a very large MACI graft, so that helps with fixation. Again, she underwent a TTO as well to unload this lateral part of her patella. So now that we have seen our case studies all the way through here from history down to their surgical management, I want to leave you guys with a couple take-home points today. First, that knee cartilage defects are common, and athletic trainers should be familiar with the clinical presentation and signs on imaging. Second, that there are multiple surgical procedures aimed at cartilage preservation, each with unique considerations and outcomes. And finally, the goal of cartilage preservation procedure is to improve patient outcomes, keeping patients active and delaying more drastic solutions such as a total knee replacement for the patient. So thank you guys all for your attention today. It was an honor to be able to talk to you guys today. If you have any questions, I'd be happy to answer any of them for you guys. Yeah.
Any challenges with getting approval for especially these newer procedures, and options then related to that?
Yes, yeah, insurance is probably the worst part of our job, as everyone knows. And so a big part of it is we have to be very specific with when we either are looking at the cartilage lesion on MRI, or if we go in for a staging arthroscopy, sometimes we have to fudge the numbers a little bit of the size of the lesion, because insurance companies don't like to cover these bigger procedures for any lesion that's smaller than 2 centimeters squared. So we sometimes just dictate them as that size in order to help us get insurance approval. Usually if patients' procedures are denied, we can go through a peer-to-peer process, and we're pretty successful with that process because we can sit down one-on-one with a physician reviewer and explain the case, and usually with that we have good success, but the first step is making sure we meet their requirements, whether they're true or a little fudged from what we're actually seeing. Yeah.
For the athletic trainers that are seeing these patients post-operatively in their athletic training rooms for their rehab progression, can you just speak to a couple things that helps as far as like positive outcomes in the initial recovery, and things that you, like speaking more to like OCAs and osteotomies, a couple things that are helpful for their success in the initial post-op period, and then a couple things that are so important to avoid?
Yeah. Totally. So for these bigger procedures, obviously every physician's protocols are going to vary a little bit, but generalized themes here, like for osteotomies, it's a pretty common, especially if we're doing an opening wedge where we're creating a fracture in the bone and waiting for that to heal. It's going to be a very strict non-weight bearing phase, typically for 6 weeks. Similarly with our osteochondral allografts, or OATS, granted we're not doing those very often anymore, but our cartilage grafts are also going to typically be in a non-weight bearing phase afterwards, and this is going to be crucial to protecting either that cartilage graft or that osteotomy. These patients are typically placed in a CPM machine as well to help keep motion in the knee, because like we talked about, arthrofibrosis in these massive cases can be a serious concern. So we want to keep that knee moving as much as we can. And so those are kind of the biggest things in the initial post-op phase as athletic trainers to be. The bottom line is whatever protocol you're given by your physician is, they have that protocol for a reason. We're there to follow it and not necessarily deviate outside of that too far.
I'll just yell. You talked about that there weren't a lot of studies talking about various medications and how they can affect the various types of scar tissue recovery.
Mm-hmm.
Do you have a recommendation? Is there something you talk to your patients about avoiding certain types of medications, even post-surgery, or whether just having complications with it? Is there one that y'all's clinic, recommends?
Yeah, so I'm not going to make any recommendations on medication today, but but the medication that I was talking about that they're studying is called losartan. It's actually, when used on brand, it's a blood pressure medication. And so we use it at very low doses, and our clinic specifically is looking at this to see if that can help to change the types of scar tissue that we're forming to form more healthy forms of scar tissue. And so that's the main one that I was referencing in the talk about that. When it comes to these procedures, as far as post-op medications, a lot of these patients are receiving biologics of some kind at the time of their procedure, so we try to avoid NSAIDs for them for the first couple of weeks to let that biologic kind of do its inflammatory process instead of shutting that down with NSAIDs. All good?
Well, on behalf of the ATA, again, let's thank Heather for her presentation. Oh, well, they can hear me, okay, but anyway, let's thank her for her presentation. Thank you very much. Thank you.